Because realistically, while we work with physicians, it's not like the doctor's in the room with us. It's typically, but in the hospital, it's never the set time frame.
Yeah.
You know, you're never working a true 10-hour shift. Most 10-hour shifts are more like 12-hour shifts. And whereas some schools are classroom-based, but you also, like my school was a little bit of both, where we did a lot of classwork, but then we would also have what's called CI, like clinical investigation, where you have a case and you go through it as a group and you kind of like work your way through it and think about what labs you order or what you wouldn't order and why you would do that and why how you would explain that. And it depends on the rotation. So if it's like an outpatient, like primary care rotation, then you're going to the clinic and you're just there with a preceptor. So whereas PAs, very similar to physicians, it's you can, take a history, evaluate a patient with an exam, order labs, order imaging, and then you can evaluate those. And then you can prescribe medications. There's no medications that a doctor can prescribe that we can't. It's all the same.
Hello, everybody. Welcome back. It is episode 15. And if you've ever wondered the difference between a doctor and a physician's assistant, or what is typically referred to as a PA, we're going to find out today. That's something that I've always kind of wondered over the years. And I know a little bit about it, but I don't know a lot about it. But we're going to talk to Kyle today, and we're going to find out as much as we can from him about it, because Kyle's been a PA for how long?
6 years.
6 years. All right. So welcome, Kyle. Thank you for coming today.
Yeah, thanks for having me.
Where'd you grow up at?
So I grew up in Lexington, North Carolina. It's right in the middle of the state.
Yeah.
3 hours from the beach, 3 hours from the mountains. So
what about the NASCAR track? Where's that at?
It's in Charlotte. So it's like 45 minutes down the road, right down the street. Yeah.
Did you ever go to a NASCAR race?
Oh yeah.
Yeah,
all
that's
the time.
cool.
When I was a kid, there's like a small time, like racing venue called Bowman Gray Stadium, which is in Winston-Salem.
Is it asphalt or dirt?
It's asphalt.
Okay.
It's actually where a lot of the you think of like Richard Petty, Dale Earnhardt, all those guys. A lot of them cut their teeth up there.
Circle track. Mm-hmm. Oh, nice.
Yeah, so we would go me and a buddy of mine would go and we'd watch like the demolition derbies and the chain races and like.
What's a chain race?
It's where they chain two cars together, and the car in the front has the motor, and the car in the back has the brakes.
Oh wow!
And so you get to see.
Dude, that sounds crazy.
Yeah, it's a lot. And rollover contests, that was fun too. So,
who was your favorite driver back then? NASCAR.
As a kid, I guess nobody else had the name Kyle. I guess it's more popular now, but I liked Kyle Petty.
Oh, nice. Yeah.
And interestingly enough, I actually got to meet him.
Really?
When I worked a job. That's how I met my wife. Actually, I had a job that I worked. But yeah.
Really?
Super nice guy. Super nice guy.
How did you meet him?
He actually had a plane at the airport that I worked at.
Oh,
so
that's cool.
Yeah, he had a hangar there, and so he would come every once in a while and go flying. And so he would always. I worked in the fixed base for the small like city airport, and he would just come in and like want to hang out for.
What was that? The FBO? Is that what it was?
Yeah, the fixed base. Yeah.
Oh,
so
okay,
I was like one of the FBO people.
Nice. Yeah. Wow. How long did you do that for?
I did that when I was in college for about 2 years.
How did you end up with that? I mean, it's such a random job.
Yeah.
You know what I mean? Like,
I had a friend who did it. He's an aerospace engineer now, so I think it started with his dad had his private pilot's license.
Yeah.
And so he was co-owner of a small aircraft, like a Cessna. I think there was like four of them that kind of went in on it. And so he would go fly with his dad every once in a while when, because it was kind of like a timeshare. You only had so many times that were yours. So he would go fly with him and he loved it. He never got his pilot's license, but he always wanted to do like something with engineering and aerospace.
Yeah.
So that he started working there just because he knew the owner, because he was out there all the time. And then when he was going to go off to college, we kind of switched up, and I was a little closer to home at the time. So I stayed there and worked for a little while before I ultimately went off to college. And then I would come back on like holidays and stuff and would work. So
I like hearing about people's random jobs that they've had over the years, because it's usually so random.
That one was one of the coolest ones, to be honest.
I've never heard of anybody that's worked at an FBO. I know what it is, but it's like everybody's got that one weird job that, like that they've had. And it's like, well, how does that happen? You know what I mean? And then like what happens after that? Yeah. But, probably like environment, the people that you're friends with and the things that you're exposed to locally, you know what I mean? Like, yeah, that's pretty cool. What were you into in like high school? Were you into sports or anything like that?
Yeah, I played soccer, and then wrestling was kind of my big thing. Wrestling in high school, and then I did wrestle for 2 years in college.
Nice.
So, yeah.
Were you pretty good?
I think I was a better high school wrestler than college wrestler, to be honest. But yeah, I was all right.
What? There was something. I think it was like a sport. I don't remember what it was. It was like you could be really good in high school, but then college comes along and it's a whole different ballgame.
Yeah.
Like a whole different level of like athletics and athletes and things like that.
Yeah, everybody in college is, a state champion, a state runner-up. Like, everybody is good. Like, there's no... In high school, you might have an easy match sometimes where it's like a kid who's a freshman and has never done this before and it's just out there. In college, everybody's good. and we cut a lot more weight in college. I mean, that's another thing, too, is, I think you wind up dropping more weight classes for most people, unless you're like a superstar. If you want to start and you want to wrestle, be on the starting lineup, you gotta cut down.
Well, I never really thought about that. Like, so it's like when you're in high school, you can be the rock star there, and all of the high schools have their rock stars, and the colleges want those rock stars.
Yeah.
So like when they develop a team, it's like, all right, well, they got a bunch of rock stars, and the people that are still right behind them. Yeah, I never really thought of that. That's pretty cool.
Yeah, everybody's good. It just seems like. So I would say I was like probably like a middle of the road guy among the good guys.
That's funny.
So yeah, but it was cool. It was a great opportunity. I enjoyed it.
What did you study in college?
So I got my undergrad in biological sciences or biology, and my minor was psychology, and that was mainly because I was interested in research. I think when I started undergrad. So
when you say research in undergrad, so that was kind of your plan, was like you went into research, right?
Yeah, I was interested. I think I was just interested in like lab science. So I graduated high school in 2005, and then undergrad in 2009. And while I was an undergraduate, and I went into North Carolina State University, while I was an undergraduate, part of the curriculum was you needed some kind of at least semester-long research experience. And so it was kind of funny. I went to my advisor to talk to him about that, and he was like, you need to just like talk to people in labs. So I literally left his office and walked up a flight of stairs and just started walking around and like asking people whether you need help in your lab. And the second lab I went to, there were some postdocs and postdoctoral folks who were doing a fellowship after they got their doctorate.
Oh, cool.
And we're looking for undergrads. And so I just kind of stumbled into a lab and like, yeah, we do need help. So I was like, oh, okay. Well, where do I apply? What do I have to do?
That's so crazy.
And so, yeah. So then I got a job working for them for the last 2 years, pretty much of undergrad, doing genetic stuff. And then they liked me. So they actually hired me after I graduated to work for another like 2 years or so.
So working in that lab, genetic stuff, like, what do you mean? Like kind of, briefly, just what was it? What were you working on?
Well, our model organism was Drosophila melanogaster, so fruit flies, which is your common like genetic model organism that they use a lot of times at universities. It's kind of foundational genetics. So, and what they were interested in, I did two big projects. One was in aggressive behavior. So there's actually, they took, there was a guy there who took lines of flies. He actually went to the farmer's market and collected like flies like from the population in the local area, and then he bred them over a period of time, and then we would split them up. We had 30 total lines, so 10 low aggression, 10 moderate aggression, and 10 high aggression. And then we would do these like behavioral assays where we would see like how starvation would affect their aggressive behavior, how exposure to certain it was pretty cool.
That is pretty cool. Like, so what was it like? Were there certain things that's like, man, these things are all riled up because of this? Like, what would that be?
I mean, a lot of times what you do is you just like, flies have a really fast metabolism. So if you don't give them food for 12 hours, it's like starving us for a full day or day and a half. And so it's like, that's what they usually do is you overnight, you just kind of withhold food. And then the next morning pretty early, you do like an assay where you expose them to food and see how aggressive they are with regards to access to it. And so that's what they were kind of looking at, the number. And then they were trying to look at the genetics of that. So is there kind of a genetic underpinning of aggression, and can you figure out which genes that is that's responsible for it?
And what was used to measure aggression? Was it like how active they are, or
it's specific encounters? Like, so I would pretty much have to sit there and just like in this little vial, like have to watch the flies interact. And there was like 5 big interactions. So kicks, punches,
Wow.
like little like boxing encounters where they're like on their back legs, like deer do sometimes.
Really?
You know, like yeah, what they call wing threats is really like puff their wings up and try to look bigger to intimidate somebody.
Wow.
So you can see all that. I mean, you have to practice. You kind of have to get used to looking at it and know what you're looking for. But you can see all that. So
But there's like, those are like particular things, like
Yeah.
behaviors that they have. Wow. I've never heard that. That's really cool.
yeah. So that was like a lot of what I did as an undergrad, and then I did some stuff with olfactory proteins, like proteomics, after I graduated. But yeah, that was kind of the basics.
And then this lab hired you. And then what did they hire you as?
So as an undergrad, I was just a research assistant, and then when I graduated, they called it like a research technician. So it's usually someone in between, either right after undergrad, who's either thinking about going to grad school or is in grad school, and you get hired for that. And so I was pretty much an employee because I worked for the university. It was for the state. It was a state employee, but it was a cool gig. It was a fun job.
And how long did you do that for?
Let's see. I did that for almost 2. I guess I think I did it for almost 2 years. Just shy of that before I ultimately wound up going back to school. So yeah.
What did you go back to school for?
So my master's. So I got my first master's in physiology. That was because I knew after doing the research for a little while, I was kind of like, I don't know if I want to do like the research route to have a PhD. I met a lot of miserable grad students, and I was like, maybe I don't want to be a grad student for the next 4 to 6 years, depending on who my PI is. And I was like, I just wasn't sure I wanted to go down that route. And a lot of it is like, what area of science you really want to focus on? And I just couldn't make my mind up. And so I decided maybe I would be better off doing the clinical application of science. And so that's why I kind of decided I didn't have all the prereqs for PA school or med school. And I said, well, why don't I go back and get a master's and I get the prereqs. And usually when you become a graduate student, you can teach, which is what I got a job doing. So that would help pay for my education.
Yeah.
And so I got to teach and go to school at the same time.
So when you went back to school, is that when you kind of made the decision that like, I'm interested in being a physician's assistant, a PA?
I was actually torn at the time. I was thinking about being a physical therapist or being a PA. I flirted with medical school, but I never, I think, and I'm sure we'll get into it more, but the big thing with physicians is you kind of have to know what you want to work in or have an idea. I mean, some people start out with no clue, but I just felt like that was a pretty big commitment to not have any idea of what area of medicine I wanted to work in.
Oh, yeah, for sure.
So I was like, why don't I just get the prereqs, do some kind of like extra courses. I don't know that I was the best student as an undergrad because I didn't have a ton of direction. I knew I wanted to do research, but I didn't know what type of research. And so that gave me a chance to get more classes, kind of boost my GPA again, and stuff like that. So.
And what was the other thing you said you were considering? Because you kind of said you thought you were pretty sure you didn't want to go to medical school, but you were kicking around physician's assistant, PA, and then what was the other?
Physical therapist.
Physical therapist. Yeah. And what were you thinking at that time between those two?
I guess I just thought, so PA is a little more involved with regards to what you can do. So in the civilian world, physical therapists, they evaluate and treat patients. They don't typically prescribe medications, whereas PAs, very similar to physicians. You can, take a history, evaluate a patient with an exam, order labs, order imaging, and then you can evaluate those, and then you can prescribe medications. There's no medications that a doctor can prescribe that we can't. It's all the same. The prescribing ability is the same, whereas PT is just a little more limited, so it's more focused on orthopedic stuff.
Yeah.
Versus, and you do some PTs, specialize in other areas like in pediatrics or in neuros, like after strokes and stuff like that. But I guess I started to do that, and then I kind of decided I wanted a little broader scope, and that's why I ultimately went down the PA route.
Has the PA route, if has it been around for a long time? Because I remember it seemed probably like within the last 10 or 15 years was when I started to hear about it. And there was like times before that where I would never have heard about it. You know what I mean? Do you know anything about that?
Yeah, it started in the late 60s, early 70s.
Okay.
There was a doctor at Duke University, Eugene Stead. I may be butchering his last name. I know how it's spelled, but it's actually said differently than it's spelled. But so he's kind of the creator of the PA profession.
Interesting.
So he took medics that had been in Vietnam, because at the time there's still a big problem with primary care shortage of providers. And so his solution to that, he was at Duke University at the time, was to take former medics and put them through a course of study that they used in World War II to fast track the training of doctors.
Wow.
And so he thought with the experience and then this kind of accelerated course of study, he could make kind of primary care providers that he could use, that physicians could use in their practices to extend care so they could see more patients.
Wow.
So that was kind of the basis of it.
Yeah.
And then it's just kind of grown from there. I think his original intent was primary care. Mm-hmm. And it has expanded. I think the first class graduated in the mid 70s, like 74 or something like that. And then since then, it's expanded to pretty much every specialty. So PAs work in any specialty of medicine.
So you graduated with your undergraduate degree, 4-year degree, and then you are working as a researcher for a little bit, and then you decide to go back to school, and you're kind of like, would it be right to say that you're kind of on the PA track at that point? Is that where you're leaning?
Yeah.
And what had you done research like, oh, I need to do this, this, and this if I want to go to PA school? Or is it like, am I saying that right? Is it PA school, or is it a degree, or?
It is PA school. The PA degree is typically a master's degree.
Okay.
And so a lot of it is it's very similar to medical school in a lot of ways. The requirements are pretty similar. Probably the biggest differences are the exam you take kind of prior to going to school. So for medical school, it's the MCAT, the Medical College Admissions Test. And then for PA school, we typically, I think when I was going to school there, or before I was in PA school rather, that there was the GRE, and then there's some schools that took the MCAT, but the primary kind of entrance exam was the GRE, which is what I took prior to going to PA school.
That's a pretty tough test.
Yeah.
I've heard bad things about that.
I don't know. I'm not a great standardized test taker, so it was kind of like my nightmare. And I didn't do terrible on it. I think I don't remember the exact score, but I want to say, like, they say you should get, between, you should get around a 150 on each section. And it's changed from the GRE. The new GRE is basically verbal and math. And then, the goal is to get around a 300 to a 310. And I think I was somewhere around like a 310 or right below it.
Okay.
And so, I didn't have a great score, but most of the time for PA schools, they're looking at least a 300 is kind of the goal. Higher is better, with anything else when it comes to standardized testing, but that's what they were interested in. So.
Your undergraduate degree, I'm assuming that should be fairly, I don't know if fairly specific is, but like, can you have just any undergraduate degree, or you know what I mean? Like
you can, as long as you've taken the required science classes. I see. So they all have your basic prerequisites, I guess, which are all your science courses. Your biology, chemistry, organic chemistry, biochemistry, genetics, anatomy and physiology. Those kind of things are really important to have before you can even apply.
Anyone going to PA school then should look. Each school will have their own requirements, and they'll be fairly similar. Would that be?
Yeah. The core classes are pretty similar. There will be an occasional difference with regards to language. So some schools, I think when I remember, some schools require a medical terminology course, which is a course kind of based in Greek and Latin, because that's what most of the terminology comes from.
Yeah.
Which I thought was really helpful, because if you can break down the word and know the origins of the word, or know what each, like itis stands for inflammation. So tendinitis means inflammation of a tendon,
Oh, interesting.
So when you see it, even if you don't remember that specific condition, you're like, well, I know what's going on with that. So,
All right. So I have a dumb question. Is it tinnitus or is it tinnitus?
I say tinnitus for that. But,
okay.
That's another debate. I don't know what school of thought most of. I wish maybe we should put a question up there.
Yeah, because I was like, well, it's an itis, but what the itis of what? Because it's kind of like a mystery. But
yeah.
Anyway, that's a side note. But all right, so you've decided that you're gonna move towards the PA direction, and you're gonna get so it would be a master's, and is it like what's the degree called?
So my PA degree was a master of it's a Master's of Science in Physician Assistant Studies.
Oh,
so,
cool.
Yeah.
All right. And how long is that? Is this like a 2-year, if you're going full-time program?
Most of them, and it's changed in the last 5 years, but when I was in school, there were no like online PA schools. It was all in person, and which kind of stems from the fact that they wanted it to be very similar to medical school, you know? So our school was 30 months. I think the average nationally is somewhere around 27, 28 months. So there's some that are less than that. There's some that are more than that. But our school was a little bit longer because we had more didactic time than some other programs. So usually it's about 12 to 15 months of didactic education, so your coursework. And then the last 12 months or so are clinical rotation. So you spend pretty much a full year bouncing between specialties, spending a certain amount of time in each one.
So let's talk about that. When you say didactic, I remember hearing that before. What does that mean? And then when there's like clinical rotations, and I kind of have an idea of what that is, but let's start off with didactic. Like, what does that mean?
So that's your basic coursework. So
Okay.
like for us, we started in the summer, actually. I started in the summer. It was July of 2016 is when I started school and graduated in December of 2018. And so for our first, and they broke ours down in modules. So they would do modules for, it was like 8 or 9 week blocks, basically. Typically, you had 2 modules a semester. And each module was a certain like system or body system. So for us, we had one that was for dermatology. We had one that was for like infectious disease. We had one that was for respiratory, one that was for cardiac. And then sometimes you'd get kind of a catch-all with multiple things like hematology and oncology were kind of lumped together. So it's mainly just like going through the coursework, learning from the ground up. I guess it's a ton of information they kind of just dump into a matter of a year and a half.
And during that time, like, what are your options? Is there like a full-time option, a part-time option for somebody, or
for our program it was all full-time?
Okay.
So, yeah, most of us and we had a fair number of students in my class that were kind of older, married with kids and stuff like that. So it was kind of a career decision they made to just go back to school. One partner would work, and then the other one, was a full-time PA student. And it's pretty rigorous. I mean, you're in class 8 hours a day most days, and then you study probably 10 hours a day after that. So summers before and then after you're studying. So I mean, you study a lot. You work pretty hard. I'm sure my wife can tell you that I was gone most of the time.
Yeah.
I would sleep maybe 4 or 6 hours a night if you're lucky, and then you just so yeah, it's pretty intense.
And then each semester there's like testing to kind of test like what you're going, like what you're learning and things like that.
For us, it was each module. So pretty much you go through a module, and then after you've finished all the coursework, you have a full week of exams. So it was usually at least one exam a day. There were a couple days during the week that you have 2. And so it's just a brutal week where you're just studying tests. And that's all you do for the full week. And then finally, when the week's over with, you typically celebrate with your friends, with what limited energy you have, and you sleep as much as you can before the next week starts.
What happens if you fail a module?
That's a good question. Our program was pretty rigorous, so we pretty much had to get an 80 or better on all your tests. So if you don't get an 80, you have to do kind of remediation, which you fill out kind of a survey about what you messed up, what you need to work on, and then you're allowed to remediate like a couple of times. But if you continuously don't get above 80s, then they'll actually recycle you to the next class.
Okay.
So there was a gentleman in my class that had been recycled, and poor guy, he was a smart guy. He just didn't do great on a couple of his tests, and it dropped his average, and he wound up having to make a decision like, do I just get out or do I?
Wow.
And they don't let you start where you were either. You start back from the beginning.
Wow.
So yeah, he had to basically go all the way back through all his course. I think he was about a semester and a half, or he'd done like the summer semester, which is a short semester, and then he'd done the fall and struggled with the class in the fall and missed it by like half a point or a point. So he had to basically just go back and start over. So he was there, an extra semester and a half, almost 2 semesters.
And you have to pay for that too. Yeah, it's not like they're like, all right, you can try it again.
Yeah.
So what would be your message to somebody that's looking to go to PA school about like the time commitment, the studying, and not that anybody, well, I mean, the seriousness of it, like what would you say, like for that didactic, that book work, what would be your suggestion to somebody that's going to PA school?
I say this in hindsight. I think studying in groups is better than studying by yourself. I was not a big group studier in school because I'm super ADHD, so it was really hard for me to focus. But I did find out later, towards the end of didactic, that when I would get in a group of people and we would just talk about stuff, or when we'd stand up and like write stuff on a board or go through the processes, that it stuck a lot better than just doing it by myself. So I would say that is really important. Find a good study group, and that don't get like attached to the first person that you study with. Like chances are, it takes a little time to figure that out, and that's okay. Like, you're not going to hurt anybody's feelings if you start studying with somebody and then think maybe you would be better off somewhere else. They may feel the same way. You know, it's just you're adults, have a conversation about it. But yeah, I think that is the biggest thing is how you study is more important than how long you study.
Yeah, definitely.
Because the retention is what matters. You're not, in the clinical setting, you're not just like regurgitating information that you saw in a book. You're taking that information and then saying, okay, you have X, Y, and Z symptoms. That could be one of 8 things. How do I narrow it down to the one I think's most likely or the 2 that's most likely? And then how do I differentiate between the 2?
Yeah.
And that is something that is a lot easier to do by just talking through it. Because you're asking the patient questions. You're looking at the patient for specific, physical exam signs. You're looking at the labs or the imaging for specific cues. So I think that's probably the best advice I can give is, 1, don't study by yourself as much as you study with other people. You probably want to split it at the very least. Yeah. And then 2, I teach it to somebody else is the other thing I think is very helpful.
It's when you can, in that group setting, when you can start teaching each other, that's when you're really starting to build that knowledge base and like the application of it in a way, you know what I mean? Because you're kind of having to think through the problems and things like that.
Yep. And if they question you about it, then you can think about, why am I saying it that way? Or why am I explaining it that way?
That's really good, man.
That was helpful. And I wish I'd have figured that out sooner, but
Yeah, it's funny. It's like we were in law school and, so like we would get cases assigned and there was no way any one person could read all the cases. And it was our last year. I don't remember if it was the first semester of the last year or the second semester of the last year, but it was then when we figured out it was like, there was like a group of 3 or 4 of us. And the example would be if there were like 12 cases and there were 4 of us, we'd each get 3. And I would know the 3, everybody would know their 3. And then we would volunteer in class. That way we'd get left alone.
Yeah.
And we never had to be, you know what I mean?
They can't single you out and try to like pick your brain for what you don't
the group
know.
setting was good. And, we would talk about the cases and stuff like that, but it took a lot of the pressure off because you had that in all of the classes, you know what I mean? But we figured that out a little late in the game, but it worked really well. So same thing in law school too, like for probably any school. I mean, like you got to be able to organize the information. You got to be able to retain it somehow. Outlines were a big deal when we were in school. Did you guys use outlines?
Oh yeah. Yeah. I was going to say there was a girl I'm still good friends with who was a fantastic like outliner.
Oh yeah.
And so we would study together and she would make the best outlines. So it's like when she made an outline and we would beg her to send it to us. And she was of course really good at sharing it. And I still, every once in a while when I'm like reviewing stuff, when I'm going back over continuing education stuff, I still look at those outlines.
The outlines are, so this is for anybody that's like going to school at any level. Outlines are a big deal. Yeah. And I shouldn't say the best. The first outline that you can look at the start of any class is your table of contents in your book. That is there for a reason. Yep. So if you look at that table of contents, that is your basic starter outline. And then you can revise it because there might be chapters that you're going to spend a half a day on. Obviously, you don't need to know all that. You know what I mean? So like when you're revising outlines, you can like chop that out or just put minimal, like what was the big thing in that section or thing like that. And then, so there's definitely a strategy to studying efficiently and effectively. So outlining is a big part of that. And I just kind of want to throw that in there for anybody that's listening that's going to be, trying to consume a lot of information in a school setting, that outlines are a big deal.
That's 100%. Yeah. I think because it's like you're saying, it's taking a ton of information and trying to decipher what you need and kind of what's important.
You know, and figuring that out too, like, so talking to your professor and being on a first name basis with your professor, but getting from them like, hey, where are the big ticket items in here? You know what I mean? Like, because like maybe there's like 4 topics out of 10 that are going to constitute 80% of your final grade. Well, that's a no brainer. You know, you got to put your time into those 4 to 5 topics if it's 80%. And then if all the other ones if the other 5 are 20%, well, I mean, you know what I mean? You want to put some time into that, but you don't want to put all your time into that.
Yeah. Our anatomy professor used to have this phrase that we would always we picked up on after the first test or so. It was like, if he says it's nice to know, it's not, he's like, that's not a need to know, that's a nice to know. You still need to know the nice to know stuff. Like he's kind of like saying that you'll find that in the test at some point. So we always put little like notes on the side in class when it was like, that's a nice to know thing. Okay, better know that one. You know,
it's really is there. It's looking back, there really is like a way to be successful in school. And it's unfortunate that you don't learn that anywhere other than like either by trial and error or somebody is like upfront with you, you know, and things like that. You know, it's kind of funny because I really didn't learn how to study until I was in law school.
Yeah, I think undergrad doesn't really prepare you for that. Honestly, probably the best preparation I got was I did the master's first. And the bulk of my tests in graduate school for my degree in physiology were essay tests. And so there were a few multiple choice. And the multiple choice was honestly worse than the essays because it was all those like, you could get it narrowed down usually between 2 choices, and the 2 choices were so similar. It was just like flipping a coin. You just weren't sure.
Totally.
So the essay tests were honestly easier because it was just like, I can just tell you everything I know about this because I've spent the last, 2 weeks. Just pouring through the book and writing it on a marker board and going through every process. You can listen to the lecture 6 times. And so,
multiple choice are definitely like way harder. Way harder because it's just like you said, there's 4 answers. 2 you can just say, oh, those aren't it. And the other 2, guess what? They're there for a reason. Let's see if you know what you know.
Yeah, and I remember the third order questions when I got into PA school were a challenge. I remember those in grad school, but in PA school, it's like for example, in anatomy class, it was always something like, what is the action of the muscle that's innervated by this nerve, right? And so then you got to know what the nerve innervates. You got to know what the muscles that it innervates, and then you got to know what do those muscles do. That's really looking for like the third order kind of thinking, or what, like what nerve innervates the muscle with these you know what I mean? Like it was something crazy, always crazy like that.
What does it innervate mean?
Just the nerve that kind of like goes through the muscle and it causes it to act in one way or another.
So you get through the didactic, and so now you're going to clinicals. And is this like, once you're done with the didactic, is it really like you're kind of done with the book work and you're really kind of moving on to like more hands-on type stuff?
Well, you're just not in class all day, every day. You're still studying in the evenings because a lot of your clinical rotations is when you learn about. They would organize it like by modules, but they would have a topic list. So so there's like a list with the certifying body for PAs of the most common conditions in dermatology that you're going to need to know for the certification, for the national certification exam. And so that's how they kind of teach it. It's like your table of contents. They basically want to go through all those, tell you the etiology or the cause of that condition, the pathophys associated with it, what signs and symptoms you see, how you treat it. And then, you do that with everything pretty much. So that all that information is in your brain, but then you have to start taking that and applying it to, it's like one thing to talk about psoriasis, but then have you ever seen a patient that actually has psoriasis, or have you just seen a bunch of pictures in a textbook? So it doesn't present, nothing presents like the book. That's always the fun part is patients don't present like the textbook. So when you first see somebody with something, it's a lot more thinking, I think, involved than just like, oh, that's it. It's a lot more.
And the more exposure you have to like all these different variations of like the same. Yeah.
That's the other part of the reason they do the clinicals for so long. It's because every time you see a condition, it's going to present differently.
Interesting.
There are patterns, and that's kind of the goal of the clinical training, is for you to pick up on the pattern.
How long does the clinical rotations go for?
So ours was usually 12 months, 12 to 15 months. I think ours was like 12 or 13 total. We did a little bit of extra. Our last semester of didactic, we did like a couple of 2-week rotations in different specialties. And so just to get more exposure early on, kind of get you an idea of what you're going to be seeing and how you have to think about that stuff and what you should read. Because every day at the end of clinical, it's like you come home and it doesn't matter how long your shift was, like you should read for at least an hour.
Really? And when you're doing the clinicals, is there kind of like a syllabus to that? Like, hey, you're going to go do like feet, and then you're going to go do neck. You know what I mean? Or, you know, like how does that work?
Typically, you know, you have an area that you have to hit. So like, for example, our program was more primary care.
Okay.
Intensive. Every program is different, but there's certain clinicals you have to have. So you're supposed to have a rotation in primary care. You're supposed to have one in women's health. You're supposed to have one in pediatrics.
Okay.
Emergency medicine, surgery. Those are like the big 6, I think, that come to mind. But then I think we had a total of 8 different rotations. Most of them were 6 weeks, and then one was like 10 or 12. And so I think I did my last one in like an urgent care, which was kind of a mix of everything. But well, you know, you have your big ones that you have to do, which is part of your curriculum, which are required to graduate.
Yeah.
That's for the program to maintain its accreditation. They have to give you, you know, those big rotations so that you're clinically trained, you know, to sit for the national board exam.
And what's happening during those? Like, how are you getting graded? Is the person you're doing the clinical with, like, I'm assuming somebody's supervising you?
Yeah, they call me your preceptor, your clinical preceptor. So for us, it's either a physician or a PA.
Okay.
Although sometimes we worked with NPs too, nurse practitioners. And so you're basically kind of their shadow, if you will. Depending on the rotation and depending on the preceptor, they do it. Everybody does it a little different. Most rotations were you kind of get to know your preceptor. Once you get, for the first like few days or first week, you go in and you kind of see how they evaluate patients. So they kind of take you in with them as their little shadow. You listen to them do a history, watch them do a physical exam, see how they do it. And then once you're comfortable, or they're comfortable with your skill set, they usually ask you questions like, what do you think's going on with this patient? And then you're going to say, well, I heard them say X, Y, and Z, and I think they've got this going on, or or they're going to ask you like, what test would you do to figure out what's going on with this patient, or what do you think we should do next? That's usually how it starts. And then when they're comfortable with you, they kind of send you in on your own. You get your own history, you do your own physical exam, and you go back to them and say, okay, I saw John Doe. You know, he's a 58-year-old male with these comorbidities. He came in complaining of right shoulder pain. It's been going on for a month. He had a fall, you know, a month and a half ago off a ladder, and I think that's related to it, and here's why. So then you kind of like tell them what your plan is. And they usually will say, that sounds good, or like, well, did you think about this? Or if you're totally off the mark, then they'll say, I think you missed something, and here's what it is. A lot of it's based on the preceptor, but I think, to be honest, most of my preceptors were great. I didn't have any issues. They're all a little different, so you kind of have to like roll with the punches, and not everybody's going to have the same learning style or the same teaching style. So you just kind of have to learn to work with what you're given. But it's the same thing with patient care. Not everybody's going to be as open about their symptoms, and sometimes it's harder to get a history out of some people than others. So it's a good training process for that.
How long does each rotation last?
So for us, I think ours were, I think the big ones were 6 weeks.
Okay.
And then I had, like my final one was like 8 or 10. And it will vary based on the program. So some of them are longer, some of them are shorter, but for the most part, it's around 6 to 8 weeks for most of the clinical rotations.
So let's use a 6-week example. What are you doing during the week? You're going to like a clinic each day.
Yep.
And then are you there like working, you know, with that person every day, like for 8 hours a day?
Yeah.
What does a typical week/day look like during a rotation?
It depends on the rotation. So if it's like an outpatient, like primary care rotation, then you're going to the clinic and you're just there with a preceptor. So if the preceptor works 7 to 3, that's when you work. If they work, you know, if you're in the ER and your preceptor works, 12 to 12, then that's what you work.
And what's the preceptor again? I'm sorry.
And the preceptor is like who you're working with.
Got it.
So who your clinical supervisor is, be that a physician or be that a PA or an NP. But that's the bulk of what it is you just show up and you're there when they're there. And when you're not there, or when they're not there, then your free time is whatever you want it to be. But usually it's studying or trying to catch up on sleep or trying to get ready for the board exam. That's a lot of the spare time is what you do is that, because you still have exams. Like we would come back through usually halfway through the clinical rotations. I think we had an exam, and then at the end of each semester, we would have an exam. And it's kind of a cumulative exam to prepare you for the national board exam.
I see. So so there's still like book work that's happening, but it's in preparation for the exam at the very end. And
you're not actively in class, but there's still, like I was saying, there's a topic list.
Got it.
So that topic list is the guideline to your certification exam. So you have to know all that, and so they're kind of counting on you to be studying in your spare time, so that when you get those clinical questions in the exams, you're ready to kind of work your way through them and know what you're doing.
So that must be pretty hard then, because you're basically at work during your clinical rotations, and you have this requirement that you have to meet academically for knowledge base so that you can pass the exam at the end. So what is that like, trying to juggle both of those at the same time?
It's challenging. It's pretty rough, to be honest. Like I said, I feel like the biggest thing I learned in medicine was how to go without sleep. So you just work a lot, and you get, most of the time, most of my rotations, I think we probably would average. And you have our hour requirements, so that's kind of the with physicians, they have so many hours because their residency is done. They're paid for their work. They have an hour limit, which is a new requirement in the last like 15 or 20 years. It used to be there were no hour limits, so they could just make you work as much as they wanted to.
Wow.
PAs still don't have hour limits. So, I had rotations, like my hospital rotation was with one of the docs I worked with while I was an Army medic, and we did 24 or 12. So if he did 24-hour shifts, you'd have 12 hours off, and you'd do a 12-hour shift. Then you'd have 12 hours off, and you'd do a 24-hour shift. So it was just like,
wow. And
we did that for 6 weeks. So it was like I was probably working 80 or more hours a week.
That's insane.
So I pretty much just lived in the hospital. They had like extra rooms that were like the call rooms, and so it was like when I was done with all my rounding and done with all my notes, I would go to the call room and like just sit there and try to sleep until the phone would ring, which, it's always, you get like 5 minutes into sleep and the phone rings and something. You have to go somewhere and do something. So you just get really good at just working a lot and not sleeping. But I will say the more time you spend in the clinical setting, the better your knowledge base gets. You still need to read, but I probably learned more in that rotation than I did in any of the other ones. Not that I didn't learn in the other ones, but that one, like I saw the patients. I admitted patients, I followed them through their course of admission, and I discharged them, and I got to see every aspect. And because I was always there, I didn't miss things, by being gone. And so I think it made, I remember coming back from rotation, one of my classmates was like, what are you even, I didn't learn that much in my hospital rotation. I was like, well, mine was pretty rough. Like it was great, but it was really, really rigorous. So.
And where was this one at?
This one was actually in Eastern North Carolina, in Tarboro, North Carolina, which is probably 45 minutes from Greenville, which is where East Carolina University is. So one of the doctors I worked there was one of the, he actually is dual certified. He's a hospitalist, so he has a dual certification in internal medicine and pediatrics. So he would do both.
Which rotation was this? Was this like a general practitioner or?
This was my hospital-based rotation. So usually you do one either in internal medicine, and internal medicine is just adults, so pretty much patients 18 years and older. And then you want to do one in a hospital type setting. Yeah. So it used to be that primary care doctors were the ones who saw you like in your like outpatient clinic, and then they also had admission privileges at hospitals. Yeah. And then probably in the last 20 years, the emergence of what they call a hospitalist came about, where they're internal medicine trained physicians or primary care medicine trained physicians, but they exclusively work in the hospital doing admissions. So like if someone comes in the ER and they have, appendicitis and they need to be admitted ultimately to go to surgery, and then they kind of want to be watched for 24 hours. That's their job, is to come into the ER, talk to the ER doctor, and this patient needs to be admitted. Okay, why do they need to be admitted? You do your kind of history and physical, and then you admit them. And then your job is to kind of round on those patients. They're your responsibility, and to make sure that everything's kind of taken care of.
Which rotation was your favorite?
Probably that one, because I got to do the most. But I had my last rotation in urgent care was really good, because it was at a small, like not super rural urgent care clinic, but it was small enough and busy enough with they had a lot of supplies on hand. So I just got to do a ton of stuff. I did a ton of procedures. When I did, I also enjoyed my women's health rotation, which was in the same place that I did my hospitalist rotation.
Yeah.
Because the doc I worked with was just really awesome. And so he taught me a ton of stuff. I delivered 5 babies.
Wow.
And I was in on a bunch of C-sections with him. So I got to do a lot of cool stuff.
Yeah, that's crazy.
I think rural rotations are better, in my opinion, because in that area, at least people were used to students. So you have the right as a patient to say no, like I don't want you to see me.
Sure.
I didn't experience that very much as a student. Most of them are pretty open to students, and honestly, you're actually better off seeing a student with a provider, because then you got 2 sets of eyes kind of evaluating you as opposed to one. It takes longer, so some people don't like that, but for the most part, they were all used to students. So I just got to do a ton of stuff on my women's health rotation that a lot of my classmates didn't, because it was kind of and I knew the providers. Like, it was people that I kind of knew through, started with that doc that I worked with in the military, and he knew somebody. So it was it was helpful to have those connections. So, but yeah.
So you get through your clinical rotations, and now you're getting towards the end of school. You're about to get your degree, but you're also preparing for this exam. What is the exam?
So the national certification exam, it's called the Physician's Assistant National Certification Exam, the PANCE, the PANCE.
PANCE.
It's a 300 question test.
Oof.
So it's 5 hours. So there's basically 60 question blocks.
Is this multiple choice?
It is multiple choice. It's a computer-based test, and it's one of those tests that learns too. So it sees how well you answer a question, and then it will kind of, if you answered it, it starts with an easy question. If you answer the easy question well, then it'll give you a harder question and a harder question until it finds your general aptitude, and then it'll just bounce you between kind of moderately hard to hard, depending on how well you're doing.
Interesting.
And so, and you get, maybe 10 minutes between each section. It's usually once you finish a section, there's a little break period if you want to take it.
What would be an example of a section? Like heart or something like that, or?
I guess, they have all the major areas that they want to hit, but it's not divided like the modules were.
I see.
So it's pretty much anything in any section, but they're going to go through, and there's a layout online actually, but the bulk of the test, probably 30 to 40% of the test is cardiology.
Okay.
And then you've got 20% respiratory, and there's a small percentage of dermatology and infectious disease and hematology, orthopedics, women's health, pediatrics, all that's in there. So they just kind of lump it all together, but then they split it up based on the most common stuff that you would see in clinical practice. So
this is a national test. So you get your degree at a physician's assistant school, and then everybody is taking the same PANCE test.
Yes.
And what does that allow you to do? What is that? So it certifies you as a physician's assistant. You got the degree. Now you're going to go get, would it be correct to say that's a license now?
It's your national certification.
Okay.
So it basically qualifies you to apply for state licensure, because you still there's still state-based license requirements.
Okay.
And state laws that kind of dictate how you practice. But to even be able to get a state license, you have to be typically nationally certified.
Okay.
Yeah.
So let's go back just a little bit. Cost. 2 years. I'm assuming there are a university could have it, but then you could also go to a private school. Would that be correct to say?
Yeah.
And price differences between the two, the public school, as long as you're a resident, it's going to be cheaper than the private school.
Yeah, it's typically a lot cheaper than the private schools.
Any recommendations when it comes to that? When people are looking at schools, costs and things like that?
I don't think it really matters where you go. I think that was a big thing when I was looking at schools. They have all these rankings for schools, and like you tell yourself you want to go to like the best school you can get into. I don't think it really matters. I think the biggest thing that matters is one, how they do the curriculum.
Okay.
Because there's a little bit of variance in how that's approached at each school. So you want to look at the school really closely and see how they break up their modules, how they do the learning. Some schools do only, it's kind of like a clinical reasoning style where they basically like give you a case and you go through it with all your classmates, and then you look up the stuff you don't understand about it and bring it back together. And it's less classroom based than it is more. And whereas some schools are classroom based, but you also like my school was a little bit of both, where we did a lot of classwork, but then we would also have what's called CI, like clinical investigation, where you have a case and you go through it as a group and you kind of like work your way through it and think about what labs you would order or what you wouldn't order and why you would do that and how you would explain that, and then what the results look like and how are you going to interpret that. And so I think that's helpful, but I don't know that I would have liked just that. I think having the actual didactic stuff where you kind of sit there and go through the motions of each condition and learn the basics is also very helpful. So to me, that's really important. And then how they do their clinicals.
Okay.
So some schools, like I looked at one school actually in Oregon, and they don't really set up your clinicals. It's kind of up to you to find a preceptor and get everything organized for each specialty. So that involves a lot more connections.
Yeah.
So I was lucky that our school typically set them up. You could find connections if you had them. And some of the ones are harder to find than others. Like typically pediatrics and women's health are harder to get.
Yeah.
Just because there's less specialists or there's less availability. So it was helpful to know, because I was in the Army, I knew a doctor that I worked with who gave me a letter of rec to get into school, and I knew he could help me with the hospital, and then he had a connection for the women's health. So because they didn't really have a lot of those for me, and so it was helpful to have those kind of set up on my own.
Now, I might be getting a little bit ahead of myself because I want to kind of talk about the difference between like doctor and physician's assistant, because like when we're talking about prescribing and things like that, you're able to prescribe drugs, right? So is that a part of the curriculum at some point Okay, so let's talk about that a little bit because I'm curious about that. Like, when are you learning this? Is this during the didactic, or is it kind of like the whole time?
It's the whole time, but the didactic for us was split up into, I guess the best way to say it is, so we would do pharmacology course. So each block of your day, there's like an hour and a half of a pharmacology course, and it's module based. So usually it's like when you're learning respiratory, you're learning the respiratory medicine. So you're learning like inhalers that you use, the most common treatments for like asthma, COPD. When you're doing cardiology, you're learning the blood pressure meds. You're learning besides the blood pressure meds, you're learning like the rate control meds. So like for AFib, like what medicines do you do to use to control the heart rate? So all of that it's kind of like done together. So at least for us, that's how it was. And I like that curriculum style because it's a lot easier to learn versus some places they just kind of like, start from one end and go to the other. But that's typically how they do it, is in the chunks of modules. So in each like system, you're learning not only the conditions that are common in that system, you go through what the condition is, what population does it exist in, what causes it, how does it progress, and then how do you treat it, and then the treatment is part of the pharmacology. And then we also have a lab course. So like physical exam, for example, what physical exam would you do on someone with a respiratory complaint or a cardiac complaint? And so you're learning all the right ways to do that. And you're tested on that as well, too. You have like a lab course where you have to kind of show how to do an exam for like a neuro exam or like a cardiac exam or a dermatology exam. So all that stuff is kind of encapsulated into the didactic portion. And then you have to make that happen in the clinical side of things as well.
For the master's portion of this, that's where you get your degree. Is there like a test at the end to get that, or is it kind of like you're just meeting the requirements to get to the degree, and then you're taking the PANCE? There
was a final. You have a final exam at the end of each of your clinical cycles, and then there's a final exam once your final round of clinicals is over with, there's an overarching, it's almost like a practice pants.
Got it.
Where it's the same duration, the same length of time, the same number of questions. Well, at least for us, that's kind of how it was. Or pretty similar to that. I don't know, it might not have been exactly like that, but it was basically a final and it's overarching over everything, you know. So you're basically having to know, you know, prepping for that and taking that test was a good kind of prep to take the national certification exam. So.
Okay, and is there a prep course that you can take for the? Do you call it the PANTS? Is that what you call it?
There's several out there.
Did you take one?
I never took one of the sponsored ones. I was able to get. They had these things called pack rats, which were like basically like practice tests.
Okay.
And I don't know how we got them. Someone had like found them online or something, and so, or maybe it was the faculty that had some, and they just kind of distributed them. And were like, these are good, these are old, but they're good practice tests. Like you should be able to go through these.
Yeah.
And they're helpful because they not only have the style of questions you see, but then they have the answers with like each one explained. So why is this right and why is this wrong? And so I took a lot of those. I think there's 5 or 6 that I had, and I would go through, and there, you know, several hundred questions of that. Yeah. So, and then there's online stuff where you can go and take practice tests online. We honestly would share a lot of information between each other. And like I use this site, like here's my login. If you want to use it, go do that. Here's my login to do this. And we would just split back and forth because it's expensive. So we would just honestly share. I mean, you're a student. Cool. So, but yeah, that's the best way to practice is the tests, is to do the questions, because that's what, you know, that's what you're going to be seeing on the actual test is multiple choice questions. It's all like, you know, John is a 60-year-old male with these, you know, past medical history, and here's his medical problems, and here's what he's coming in for. And they're going to give you vital signs, they're going to give you lab findings, and you're going to have to like try to cipher through that, you know, on a computer screen in a timed fashion. And so it's just like you just need to get really good at picking up on the big keywords and the what's changed or what are they really asking for, that kind of thing.
So is the PANTS, is it pass fail?
It is. You get a score, but realistically, I think your score is just kind of tell you how you did, and it shows you your areas that you did well and the areas you didn't do well. And it's I want to say like it's between 200 and 800, I think is the score, and then like a 3 or a 350 is passing. But I don't remember my score at all. I just remember congratulations, that was the email. I was like, yay.
Totally.
Yeah. So and I looked at the breakdown afterwards, and I was like, okay, maybe I should really restudy some of this stuff that I wasn't as good at. But it's just a generalized medical education test to kind of like prepare you for practice. A lot of what we do is once you get into a specialty, you work with the provider that you're in that specialty with to kind of get you trained up on how to evaluate certain conditions, what meds they like to use and why, and what procedures, you know, you feel comfortable doing. Because you get a lot more information than you may wind up using in practice. You know, for like my best friend in school he's an ortho PA now, so he's not doing respiratory diseases. He's not doing really a lot of cardiac stuff, but he had to learn all that to be be a PA. So it's like you still know it, and it's still required as part of the recertification exam. Although it's changed in the last few years, they're starting to do more specialty based stuff, and they're also doing take-home tests now, which they used to not do.
Interesting. Take-home tests.
Yeah, so it's kind of like you can either sit for the recertification exam like the old school way, or you can actually take it home. And that doesn't mean it's any easier. Usually take-home tests are much harder, and you can use your resources. I think they went to that because that's more realistic of practice, right? It's like if I don't know an answer to something, I can still go look it up.
Sure.
So, and I think with the busy clinical schedule that most providers have, having the time, it's like working a full-time, just like being back in school. It's like working a full-time job and still having to study in the evenings is pretty rough when you have a family and stuff like that. So
if you fail the PANTS, can you take it again?
Yes, you can do it every 90 days. So you basically can do it up to 3 times a year. It's kind of the regulations. So if you fail it, you have to wait a full 3 months before you're able to take it again.
Okay.
But yeah, I don't know too many people from my class that didn't pass it the first time. And a lot of programs too, when you look at, I guess that's something I should have mentioned. When you look at programs, you really want to look at their first time pass rate on the pants, because that's really important, because that kind of tells you that the program prepared you well enough to
That's
take
a big deal.
Yeah, and that's typically listed somewhere on their website. I mean, you can find it usually when you're going through how they do the schooling, how they do their program.
Yeah.
Most of them are very proud of their pants pass rate, so they're going to put it on theirs for you to be able to see, because that's how they entice your potential students to come there.
What would be like a good pants pass rate for a school? Like a good school?
Like 95 or better.
Oh,
is typically
okay.
good. I want to say ours was like 96 or 97.
Wow.
Like it was pretty high.
So they're being I'm assuming they're being very selective who they're letting in too.
Yeah, that's the other thing is, getting in is its own challenge, and they're very, very picky about who they, because, that reflects on them, right? If you come in and even if you pass, but if you pass all the courses and you're able to graduate, but you don't pass the pants, then that's kind of their whole point. So they didn't really prepare you as well, or you weren't perhaps the better student that they wanted. So yeah, that's part of the kind of draw for them, and then the challenge for you, I guess, is the combo.
It's weird for me to like look back and see how it all works. After you're all done, it's like, oh, well, like bar pass rate, like we want people that are going to pass the bar because we have this bar pass rate. So, you're not going to get it here. You know what I mean? But, but doesn't mean you're going to pass, or that person won't pass. But it's kind of crazy that it's like very selective in that sense. And, just looking back. So you passed the first time.
I did, yeah. Thankfully.
So
it was on pins and needles there for a little while. It's like, I remember most people walk out of the test, and we all talked about this, all my friends, we walked out of it like, well, I failed, like I can't wait, 3 months from now I'll be taking that again, it's like, but then most folks that feel that way typically you do well. I mean, or you pass. I don't know, doing well. Like, to me, doing well is just passing. Like, I know you get a score, but the score is less important than passing. None of the employers care about your score. They care about the fact that you passed,
So what's the next step after that? Is it to get licensed in a state?
Yeah, that's the next step, is depending on what state you're going to practice, the licensure requirements are different in every state, but most states, you have to have some kind of either current employment or offer for employment before you can apply for a license.
Okay.
Or at least, you have to have somebody that you're going to be working for in that state for them to validate, okay, yes, we'll give you a license, and you just got to fill out the application and, give us all your educational requirements and the address of where you're going to be working, and you need to have your DEA license and all that stuff. So
pay a fee.
Yep, pay a fee.
Is there a test or anything, or is it just kind of like, hey, we need all this information and we need you to pay some money and then we're going to give you a license?
So I think the state of California does have like a legal component to the PA practice. So I think you either have to take a class, or I think you have to pass some kind of
like an ethics exam or something like that.
Something like that, or just going through the legalities of what you're allowed to do.
Okay.
It's the only one I've ever heard of, but most states, it's like once you've had your national certification exam and you pay the fee and you submit all your documentation, and it's they verify it's not fake, that they can give you your license. And then you just have to have so many hours of practice in that state to maintain the license. And, you have to have continuing medical education every year, but the requirements for the state are usually lower than the national certification. So
you said something earlier, and I never really thought about it, but it's implicit in the name physician's assistant that you're working with somebody. And this would be a doctor?
Yes. And it's kind of funny that you bring that up, because like 2 or 3 years ago, there was a push. The physicians have the American Medical Association as their kind of advocating body, I guess you would say. And then PAs have the American Academy of Physician Assistants.
Okay.
So 3 years ago in 2021, the AAPA decided that they wanted to have the name changed, which they've been talking about for probably the last 10 or 15 years, and it's just never really kind of gone through. But they finally passed this kind of legislation in their House of Delegates, their governing body, saying that they want to change it from physician assistant to physician associate, physician assistant to physician associate, because I guess they don't like the connotation that we're the assistant to the doctor.
Yeah.
Because realistically, while we work with physicians, it's not like the doctor's in the room with us. It's typically, depending on the state, it's like you have this kind of license agreement where there's a physician who's in charge of you or going to review so many of your charts a month.
Sure.
but that's really all. It's really just kind of a legal agreement. There's not as much oversight. So 9 times out of 10, like I every once in a while, if I have something I'm just not sure about, I'll go and ask one of the physicians in my practice.
Yeah.
But they're not in the room with me. Or if I'm thinking it might be one thing and I just want like a second set of eyes or a second set of ears, then I'll go grab one. And physicians do that too with each other. But most of the time, you're kind of practicing on your own.
Sure.
So that's the biggest thing is that, at least in Arizona, like I'm required to have what's called a supervising physician, and it's a legal agreement. So someone has to agree that they're going to do that and sign that, and then they have to, there's so many charts a month they have to review. During the early stages when you work for them, that number is higher, and then as you've been there longer, like that number tends to go down.
So what would you say is the primary difference between like somebody that goes to like medical school to become, let's just say, a general practitioner doctor and a physician's assistant? What are the primary differences? Because both can prescribe medicine, both can, where is the line?
Well, the length of school, so medical school is 4 years. PA school, is typically 1.5 years. So it's the amount of time you spend. Typically in medical school, they do get into more of, I would argue we do everything on the surface and there's some depth, but I don't know that it's at the level with regards to like microbiology, or we learned that prior to going to school, and then they kind of hit it briefly. It's just not as stressed. Like I don't remember, like we didn't do like cell structure stuff or tissue sampling or anything like that when I was in school. We knew the basics, we knew what a biopsy was and what the results might mean, but I think medical school goes a lot deeper with that stuff. Yeah. And the other thing is a residency. The really biggest difference is the residency. I was just about to ask about that. Yeah, the schooling is longer for medical school, and then the residency. We're not required to have a residency because we work kind of collaboratively with a physician. Sure. So we're training on site, but it's kind of like, when you first start working, they kind of see what you know, what you don't know. They work with you on it at the beginning, and then you kind of are cut loose to see stuff on your own. And then it's on you, if like you don't understand a problem, or if you have a patient with something that you're just not sure about what's going on. Yeah. Then it's your responsibility to be like, well, do I start the workup this way or do I start it that way? Or sometimes I'm like, if you're between two things, I just go to somebody and say, hey, here's what I got. What do you think? What would you do?
So when you, where did you get licensed at first?
Actually here in the state of Arizona. And so, because I got I did a scholarship program through the military to pay for my PA school. Oh, nice. And so once I got out of school, once I graduated and became certified, they moved us out here. We went to school in Virginia, and so they moved us out here. And in the military, you're not required to have a state license, because as long as you have the national certification and you're operating on base, then that kind of is encompassed in your care. I guess your provision of care is considered, federally valid. That's probably not the best legal way to say it, but it's basically you don't have to have a state license, because you can pretty much practice anywhere that's on a military base. Sure. I went ahead and got my state license anyways, because at the time I was thinking like maybe I'll work like part-time, a civilian job. I never wound up doing that, but I went ahead and got my state license within the first 6 months or so I was practicing. And then I've just kind of maintained it since then. And then when I served my time with the military, I went ahead and got out. And then I got civilian jobs since then.
So where's the military at in this? Is like, are you in the military while you're going to school? Are you know what I mean? Like, because they paid for your school. So what branch were you in, and what were you doing? And like, how is that all related?
So I did the Health Profession Scholarship Program, HPSP. It was through the Air Force. And the way that program works is, you apply for the scholarship. If you're awarded it, then you're commissioned while you're in school. So you get commissioned as a second lieutenant while you're in school. It's a pretty great program because they commission you, and you're earning like a O1 pay while you're in school. Wow. It's not considered active duty pay, so you don't get like certain like
you're not getting housing allowance.
Yeah, you're not getting certain like add-ins like that. It's just kind of like the base pay, but they give you that every 2 weeks, and then they pay for your tuition. So you pretty much have your tuition bills sent to them, and they cover it, and they pay for your books. So like you basically buy your books and they reimburse you. Is kind of how it works.
Oh, this is huge. All right, so I completely missed this, so we're gonna go back a little bit. Yeah. So is this happening while you're in undergrad that you're looking at this and you...
If you're smarter than me, yes. It's not something that I did as an undergrad. I had a pretty circuitous path, to be honest with you, to medicine, because I did the master's degree, and then actually after the master's degree, I took like 3 years before I ultimately went back to PA school. So it was a little bit longer for me.
I see.
Because that's when I was working as, and I was in the National Guard and doing other jobs to get more clinical experience. But typically, yeah, in undergrad, if you're going straight to PA school, that's what you should be looking at, your junior, senior year of something like that, some kind of scholarship.
And what was the scholarship called?
The Health Professions Scholarship Program.
HPSP.
Mm-hmm.
HPSP. All right, so there are these scholarships that exist out there for, and these are like military related. So
that one is. There's actually other ones. So there's ones through the National Public Health Service that you can do, where you work either in like where you can be employed in their service and they'll pay for your school. Typically, it's more of a payback system where if you do that, then they'll help pay back your student loans, or they'll pay back on what you got, but you have to work for them in a specific area for so many years. And then there's another one now that they have where if you work so many years for in like an underserved area, what's considered underserved, I think one of my friends is doing that, where if you work 10 years at a facility that serves an underserved population, then they'll basically pay back what's left of your student.
Yeah.
You still have to pay on your loans while you're doing that, but it's like a minimum payment pretty much every month, and then whatever's left they'll pay back. So
how did you find out about the HPSP?
I found out about it because I was Army National Guard medic. I did that. Actually, I finished my master's degree and then joined the Guard to be a medic so that I could get clinical experience. I could have a little more time as working as a medic. That's how the profession got its start. So for me, I was like, why don't I just start from there and see what it's like? And two, I didn't really know anybody in the medical profession, and you really need to have some kind of connection. And so it was kind of a long shot, but I was like, I'm going to do this, and I'm going to meet somebody, and I'm going to show them that I'm not an idiot, and they're going to write me a letter of recommendation. Like, that was my logic, which is kind of far-fetched in hindsight, but it worked out. But so that was really my goal with that. And then it was during the time of being a medic that I found out about it. And I think it was just people I talked to. There is a program through the military where you can become a PA. Typically, you're an enlisted member, and then you decide you want to do that program, and you have to do all the prereqs. And if you get selected, then you're commissioned. And while you're in school, you're still that one's for active duty PAs. So typically, although I think some Guard and Reserve folks are pulled into it and activated to active status, but that one is down at Fort Sam Houston in San Antonio. I had a good friend that I shared an office with when I first started my Air Force gig who did that.
So you were in the Army first, you said?
I was in the Army National Guard, yep.
At what point did you join the Army? This is an enlisted, right?
Yeah, so it's funny. I graduated with my master's degree I think I graduated in like the December of 2012 or something like that. And then in March or April of 2013, I went to basic training with the Army and with the Guard. And then I went to medic school after that, which is 4 months at Fort Sam Houston.
Okay.
And so I did all that because I needed a lot of, I guess I didn't mention that, but a lot of programs, not in addition to the academic requirements, the courses, you have to have so many hours of clinical work. So the average varies. Usually the minimum is like 1,000, but most places you need more like 2,000 to 4,500 or something like that. So I was in the state of North Carolina at the time, and I had already got my CNA license, like a certified nursing assistant, so that I could get a job working in a hospital. I was lucky because in North Carolina, you can either do a course or you can challenge the state exam. And I was
wow.
I challenged. I just basically learned all the skills I needed to know. YouTube was my friend, right? Because I just went on there and learned all the basics from there, and I did all the reading on the coursework and just went and sat for the exam and passed it. But that wasn't enough clinical experience. I knew I was going to need more than that. So then I was like, why don't I just do this? So then they'll pay for it. It would give me an opportunity to practice. And then, like I said, my goal was to find somebody, that I could work for, that I could kind of show this is my knowledge base. I'm smart. Like, will you write me a letter of recommendation?
And what was the letter of recommendation for?
The letter of recommendation is for school in and of itself. So getting into PA school, typically they require 2 or 3 letters of rec. And I think it helps to be, it's more weighted to come, like you typically want it to come from, at least 1 to come from a PA, and then 1 or 2 to come from a physician or another PA or an NP or something like that. So
you get a master's that is not related to your master's in physician's assistant. Mm-hmm. Okay. And then, so you get that first master's. What's that one?
So the first master's was in physiology.
Okay. So then you get that, you go into the Army, you get like schooling as a medic. And how long are you in the Army? And then you hear about this HPSP.
I was in the Guard for about 3 years. So I had heard about HPSP prior to joining the Army, and that was kind of my goal. I'd hoped to do it through the Army. It didn't quite work out that way. I think at the time, the year that I was trying to get it, they either weren't offering it or the chain of command kind of dropped the ball, and I just like didn't get my stuff in time. So it was just, long story short, it's like I couldn't do it through them, and so that's why I ultimately applied through the Air Force. I was like, well, I can still do it. It'll just be through a different branch, but it's the same concept, you know.
So when you're in the Guard, is this like full time or is this the part time?
It's part time.
Okay.
Some Guard guys do like more like full time gig, but for me it was just part time because I was also working as a CNA in a hospital, and then I worked on a med surg floor as a CNA for about a year, and then I worked for another 2 years or so as an ER tech.
Okay.
So,
well, this is pretty huge though, because this is another alternative for people is to look into like a well, I'm not sure if I'm saying it correctly, but reserve or Guard part-time if you want to serve, but also it will be an assistance in the sense that like it will help pay for tuition for some or if not all.
Yeah, if you can get the scholarship and everything. Yeah, it was a good experience. One, because it kind of like introduced me to what being in the military is like.
Sure.
And then, you know, 2, I got training that I wouldn't get without that. Especially as a medic, like you learn a lot more stuff as an Army medic than you would as like your garden variety EMT basic. Because you get taught some advanced skills that you don't typically learn as an EMTB in the civilian world. And then we learned a lot more medications and stuff like that. And it was just kind of cool because a lot of what you do is kind of what you're doing as a PA. So your patients are coming into sick call or into your aid station, and you know, you're the first line of figuring out what's going on with them. Usually there's a doc or a PA that you work with that you're kind of running your stuff by them. And so that was a great kind of intro to medicine for me.
So when you find the HPSP, is this like a program? It's since it's a scholarship, you're applying for this before you have to be accepted into the scholarship program, and then you find like a PA school that you want to go to, and then how does that work?
I actually did it. I was already in PA school.
Okay.
So the cycle runs, I want to say like every like year and a half or something like that. So because our school starts some schools start in the fall, like your standard college. Ours started in July, so it was like right after July 4th when we started.
Yeah.
So I actually had about a semester and a half or so before the scholarship kicked in. And so it depends on where you go. If you start in the fall with your program, then a lot of times the HPSP will already kind of have been done in process, and the selection process is over, and they've already picked who they want. I mean, it will cover just about all your education. I think, like I said, mine covered a year and a half, basically with PA school for me, which was the bulk of my school. I had I had pretty minimal loans considering.
Yeah.
That's
huge.
Yeah, it was a huge difference. I mean,
that's
I've
massive.
since, like, what loans I had, I've paid off now, so I have no student loan debt anymore, and that wouldn't be the case if I hadn't got the scholarship.
Without the scholarship, how much would PA school have cost you? You think?
Probably $150,000, $200,000 easily.
Yeah, that's huge.
So they definitely saved me at least that much. I mean, I would say, and then I didn't have to take out loans to help pay for my lodging or for food, right?
Yeah.
'Cause that's part of your student loans that you take out as a student.
Yeah, absolutely.
So that was kind of covered because they gave me that base pay every month. And so it made a big difference.
So there's an obligation. They're not just handing this out for free. So what is the obligation now? So you're basically going to be commissioned. So you're going to be an officer in the Air Force. What is the commitment after that?
So they have this program for both PAs and for med students.
Okay.
For PAs, basically, if you get the scholarship, you have to serve for 3 years. At least with the Air Force, it was for 3 years on active duty.
Okay.
So and with physicians, it's typically 1 for 1. So for every year of scholarship you get, you have to serve a year. So there are physicians that do it, for all 4 years of med school, and then however many years of residency.
Yeah,
that's 3 years or 4 years, and then they have to serve 8 years after that.
Yeah.
So I was lucky that as a PA, it covered about a year and a half, and then I kind of had to serve double that. So I served 3 years. I served longer than that because I was deployed and my time actually went over. But 3 years is not that long, considering considering the profit that you save. I mean, the amount of money you save. You know what I mean? Though, kind of if you balance it out, like it was definitely worth the money.
Well, and earlier you said they're paying you while you're in school.
Yeah.
I mean, that's massive. Yeah, you're getting officer pay without like the housing allowance and the food and all that other stuff, but still, I mean, it's a good base pay.
Oh yeah.
That's super cool. I mean, there's all these like little programs, and it's like, man, you got to talk to somebody to find these like little things out, because there's probably a program for something that you're interested in.
Yeah.
And this, I've never heard of this, you know what I mean? And it's interesting that it's like, okay, well, not only are we going to pay for your school, but we're going to pay you while you're going to school. And all we're asking is 3 years of your life after that. I mean, that's like a steal in my mind. You know what I mean? That just sounds like such an incredible opportunity to, do all that. And then you go serve your country as an officer for 3 years. And that's insane.
I guess the biggest thing, it's a pretty great deal. The biggest caveat to it is, when you get out and serve, you don't get to pick where you live or where you work.
Sure.
So, and we'll probably talk more about it, but the big thing about being a PA is you're not tied to one specialty. So if you ever want to switch, you can. Whereas if you do the HPSP, the military is going to tell you where you're going to work. Yeah. And chances are it's going to be primary care or some kind of version of that for the first couple of years. And there are certainly people who, go like in school, like I had friends that was like my friend who's an orthopedic guy, we always joked like, you're going to be an orthopedic PA. And he was like, no, I'm trying to keep my options open. I'm trying to be open-minded. And he did all the coursework and he did well and everything. But it was like, he was just so good at it. It was like, we knew he was going to go that route. Yeah. So if he'd have done the scholarship or something like that, he would not have been able to work just in orthopedics right after school. He would have had to do his kind of general or wherever they put you. Yeah. Which most commonly is in primary care, because that's where they need the bulk of the providers. So that's the one caveat is like if you're really dead set on a specialty as a PA that you want to work in, like if you want to work in surgery, you're going to have to be willing to not do that for a couple of years. But that doesn't mean you can't do that when you get out. If you get out, or if you want to stay in, they do have. There's a new thing now where they're actually looking at PA residencies, where they have programs where you get. The military offers this anyways, where you can get like a doctorate, like your actual doctorate, and you do it in a specific specialty. Wow. So like there's ortho specialty PAs who have done a program that's about, I want to say it's like 2 years. And they're trained in orthopedics, but they also have done like the research aspect of it in orthopedics. And then they used to have it in like ENT and derm. I think those have kind of fallen off now. Mainly it's orthopedics is the biggest one that they have. But so I mean, there's other options available.
So you graduate from PA school, you pass the PANTS, the national exam, and then you have 3 years in the Air Force. What did you do during that time?
I worked in operational medicine is what they called it. It used to be that primary care in the military, you saw both active duty and dependents. So that would, depending on the base, that would typically include retirees or spouses or sometimes kids. Where I was stationed, they had a pediatrics department, so we didn't see kids. And because they split it right after I got out of school, they split it to where there was a dependent section, which is manned by other providers, typically civilian providers, and then an active duty section, which is operational medicine section. So that's what I did. I basically just was primary care for all active duty. So I didn't really see non-active duty folks. It was mainly just active duty for the first 3 years.
And you said you were deployed?
I was, yeah.
Where at?
I was deployed to West Africa, so Nigeria.
Okay. How was that?
That was pretty awesome. It was a great experience. That's kind of why I honestly went into the military to begin with, is because I was interested in kind of austere medicine.
What's that mean, austere?
So just kind of in the middle of nowhere.
Oh, okay.
And so I was, there's different roles when it comes to medical capabilities. And so role one is like the bare bones, so like I was in Niamey, Niger, and it was basically a tent. It was like a tent with, we had a massage table that was our patient bed.
Wow.
And so your limitations are kind of the environment, obviously, and then what supplies you have. But that was a really awesome experience because I was like the medical director of this, role one clinic, which is in, sub-Saharan West Africa. And I was in charge of the inventory. So I maintained all the medicines, the vaccines that we had, all the supplies were kind of my responsibility. I saw patients. I managed our testing capabilities, which was really awesome because then I learned, a lot of times in school you learn the tests you're supposed to do, but you don't always learn how the tests work.
Yeah.
And so that was something I got to learn when I was deployed, like how I did a lot more. When I was deployed, COVID was a big thing. So we had PCR testing and COVID testing that we would do kind of on site. And I got to learn that I worked with my enlisted folks, and they taught me a lot of things that they already knew how to do. And I was like, well, if I'm in charge of you, I probably should know how to do what you do so that, if for some reason you're sick or, if you're incapacitated in some capacity, like I can take over what you do, and I want you to know as much about what I do so we can kind of work together. So that was a pretty awesome experience. I had a really good deployment.
What a cool program, and, a short, in my mind, obligation. Like, what would you recommend to somebody that's looking to go into school and, like, researching these different options? Like, what would your suggestion be?
I think the biggest thing is, for me, it was, where do you want to live? And then two, what kind of specialty or what type of practice do you want to do when you get out? And I had, part of my decision to go to PA school was I had absolutely no idea. I didn't know what area of medicine I was most interested in because I'd never worked in a lot of them. Yeah. So I'd worked in, like I said, the ER and medical surg. So I thought maybe when I went to school, like I was going to work in the ER. I haven't since really worked in emergency med. I've done some, I did work in trauma and surgery for a while. It was one of my other jobs, but the bulk of what I've done has been kind of primary care or general practice. And so I think if you have an area of medicine you really want to focus on, that might be, you may not want to do a program that kind of restricts that. But otherwise, if you're open to just about anything, then that would be for you. Or if you're just not trying to spend a ton of money, you know what I mean? And you want to, that's another great option to save you some money and not make you take out so many loans.
So your 3-year obligation is nearing the finish line. What are you thinking during that time? Stay in, or you're like, I'm not staying in, I'm going to get out?
For me, I was ready to get out. I think I just wanted, one, we liked where we lived because we were here, and we didn't really want to move. And two, I wanted more control over basically the types of patients. Working active duty, you don't see the same type of patients in the civilian world. So you don't see older patients because I wasn't seeing dependents. I didn't see younger patients because I didn't see kids. So I was a little limited in my practice, and I wanted my scope to be a little wider. So for me, that was why I ultimately decided to get out. But there are a lot of people that do that for their career, and that's kind of what they enjoy. Some people do the primary care thing for a couple of years and then do one of those specialties, or they work to go to a specialty. And then in the civilian world too, I had friends that got out of school and they actually did, because they do have PA fellowships now is what they call them, where you spend a year kind of working almost as a resident.
Kind of like specializing in something.
Yeah, like I had one that she did a fellowship in the ER. That was kind of her thing. So she spent a full year and she got a ton of extra training and, doing intubations, doing procedures, the kind of a lot of what you don't see, I guess, as an ER provider is they do a lot of more intensive care medicine because, patient true. I mean, there's the ERs in the United States are really kind of overused in ways that they probably shouldn't be.
Yeah.
Like people come in with like a cough or a cold and it's not really a true emergency. But when you do have those real emergency patients come in, like you just had a gunshot wound or you just had like a fall and you're kind of in and out of consciousness, like your severity, your level of complexity is higher. And so you have to be able to manage that. And so part of the PA fellowship is getting us kind of up to speed on how to manage those more complicated patients.
So when you get out of the Air Force, you're coming back to Arizona. Are you licensed here at that point?
I was, because like I said, basically when I started my career with the military, I went ahead and got my license because I figured I wasn't sure I was going to stay in anyways. I was like, I'll do it and I'll just see if I really like it. And then like I said, I wanted a little broader scope, and I was like, I don't know that I'm going to get the control over that without being in the civilian world. So that was my thought. Was I just kept my license the whole time and then just maintained it since then.
So you have some experience as a combat medic, and then you have experience in the Air Force. After your time in the military, did you kind of have an idea of what direction you wanted to go?
Yeah, I think, and it's kind of changed since then. I think I really loved my hospital rotation, and so I wanted to do more hospital-based medicine. Really just internal medicine in general I like. And so I did that for about a year, and it wasn't quite the same as a practicing PA than it was as a student.
Okay.
And so that's kind of, and the schedule is very different. I mean, I worked a lot. I told you about my rotation was really intense. It was still really intense as a practicing PA, when I was working in trauma and surgery. We were supposed to work, 410s, but in the hospital, it's never the set time frame.
Yeah.
You're never working a true 10-hour shift. Most 10-hour shifts are more like 12-hour shifts.
Yeah.
Or whenever you can get out of there is kind of how it works. So
yeah, I'd imagine if you're tending to somebody, it's like, well, you're
can't
going to be done when you're done.
Yeah. You can't exactly like clock in and clock out.
Yeah.
On a schedule. It's based on needs and coverage and stuff like that. So yeah.
So where did you start? Like right out of the military, like Air Force, you come back, where did you work at?
I started in a large university hospital doing trauma surgery stuff. And then I only did that for about a year.
Okay.
And then I was like, this schedule was kind of rough. Can't have much of a life outside of this. And so then I switched kind of back to more general primary care, but it's the outpatient kind of thing. So it's kind of nice because I get a broad range of patients, but I also work Monday through Friday, right? So.
And then can you talk a little bit about like the requirement of like you're not necessarily having to be there with a doctor, but is there some, would it be correct to say that like this is the doctor that's like going to not necessarily supervise you in like
that's what they call it, the supervising physician. But yeah.
So can you go into that a little bit? Like what's that requirement? Like if you're going to be a PA, at some point you're going to have to find a doctor that you're going to be working with. Would that be right to say that? Can you talk about that a little bit?
I guess it depends on who you work for with regards to the organization. So, like, for example, where I work now, the provider that's my supervising is just he's one of the assistant to medical directors of the organization. So they hired me kind of with the anticipation that he was going to be my kind of direct supervision, if you will.
Got it.
And that just kind of means that part of the licensing process and part of the supervision process in this state is, he signs off on the things that I am qualified to do.
Okay.
And so to be qualified to do certain procedures and mainly procedures, to be qualified to do certain procedures, you have to have done so many in training. And then you have to kind of keep that competency up. So you have to continue to do those while you're practicing. So his kind of sole role is making sure that that's all taken care of. And then, like I said, typically there's so many charts a month. He has to kind of audit, if you will, and just kind of check them for standard of care and make sure that I'm meeting the standard of care that I'm supposed to. So, is what I'm doing for a patient with a certain history and condition or diagnosis, is that kind of meeting what another provider would do?
Now, I thought in the past I had heard of like physician's assistants or PAs having their own practice. Is that something that happens, or?
That's not typically the case, although it depends where you work. So in rural places, like think Montana, Wyoming, for example. You can be a PA and your supervisor might be 3 hours. Like maybe you're in Bozeman and your supervisor's in Missoula, right?
Okay.
And that's just a random example, but the gist of it is they're not always on site.
Okay.
So they're responsible for what you, and that's kind of a misnomer too. They're responsible for what you do, but you're also legally kind of like liable for what you do. So,
Yeah.
So if anything, like if you do something wrong or if you do something that might injure a patient or in some way negatively impact their outcome, then it's not just the supervising physician who's on the hook. There's some culpability in that, but it's mainly you. That's your legal responsibility to make sure you're doing what's right. So
would it be true to say then that you're building a relationship with someone?
Yeah.
And then you're establishing this trust over time. And I'm assuming in the beginning, there's a little bit more
it's definitely a learning curve, perhaps.
Learning, and then like there's more of like not hands-on, but like, hey, you're talking a little bit more, and then eventually you're starting to.
They're just assessing your competence. Really is what it boils down to. They do that by kind of seeing you work. And most of the time, they kind of start and see how you assess patients, and based on how comfortable they feel with your assessment and your presentation skills, then they look at your notes and see how are you writing this up. Are you, is that the process that I would go through, or that any logical clinician would go through, and then what does it mean from there?
So then that takes me to the next question is let's say that are you setting your own, like how much you're charging, and you know what I mean? Like how does the pay work? Like is the doctor saying, hey, I'll pay you this salary, or are you saying, hey, here's my hourly rate?
Yeah. I work for an organization. It's honestly like a corporation. So, I get a salary.
Okay.
I was hired with a specific salary. And then there are like productivity kind of standards. So I'm required to see, in medicine, they bill it as, the billing is complicated, but the gist of it is they have something called relative value units. And so an encounter, depending on how it's coded, so whatever you did determines how complex that encounter is. And then that complexity determines how many RVUs are generated for that encounter. Yeah. And then that is translated into so many dollars per RVU. So I'm required to get so many RVUs per quarter. And then if I get over that number of RVUs, anything over that, there's a set dollar amount that I get that's over that. So I'm both salary and then productivity based. So like I have to be there, I'm required to have 36 clinical hours a week, which is, I can split that up however I want to. I do it Monday through Friday, 8 to 4:15 or 8 to 4, 8 to 4:15. But then the number of patients I see is really based on who comes in, who doesn't. You know what I mean? Like my schedule is pretty much just open, and so I see whatever comes in the door.
Okay.
So
what does a typical day look like?
It depends on the time of year here in Arizona. Interestingly enough, but by and large, most days are anywhere from 18 to 23 patients. I mean, they're pretty busy. If I'm lucky and it's a slower day, it's more like 16 to 18. But on average, I probably see. And then the last few months, just because of people being out, or because in the wintertime here, we have a big snowbird population. Our population tends to go up, and so then the volume of patients that I see goes up concurrently with that. So. Yeah, usually anywhere from 18 to 23 right now is kind of the average. When I first started, it was a lot less than that. It was more like 13 to 15, and then you kind of gradually build up. But
it sounds like the difference between the 13 to 15 and the higher range is quite a bit, I would imagine, during the day. Yeah. And are you able to set your schedule kind of, you know what I mean?
Kind of, yeah.
Okay. How does that discussion usually go, like with a practitioner?
Well, there's a site supervisor for us who kind of controls that. So when I first started working there, I was just like, I want a Monday through Friday gig. So, I'll get the hours basically during the day. And I want to be able to come in late enough that I can work out in the mornings, which is why I do that. So I don't have to be there till 8. Some people come in at 7. Some people come in at 7:30. Yeah. When I first started working for the organization, I spent a month kind of getting my feet wet, working with another doc at another facility. And he works 9 to 6. So like, I don't know that they really care as long as they have the staff available during the hours you want. So I couldn't do like 12 to 12 because they don't typically have staff there after like 6 p.m. So, but by and large, at least with my job, it's pretty flexible. If I wanted to work 4 days a week instead of 5, I could change my schedule to 10-hour days, or to roughly 10-hour days, 3 days a week, and then a half day the other day. But I like the kind of 5-day-a-week thing because the volumes, usually with a longer day, you're going to see more patients because you have more slots available. So for me, it's like if I see the volume that I see, I'm usually able by 5:30, 6 p.m. to be done with my charting, done with my labs, and I can go home. Versus, it's a little different if you do more than that.
So let's talk about that real quick because you said charting and labs. So like what is the typical process? I mean, is there like a general? Here's what typically happens. I see a patient, I have to do this, this, and this. And then when I'm done, I have to do this, this, and this. Like, what does that look like? So
a patient comes in usually like for a specific complaint most of the time. Let's say you come in and you have like, a cough, right? So you come in with a cough. I go in, I usually take my computer in the room and I kind of have a conversation and I usually type while I talk, kind of like go back and forth. I asked you about what's going on, what kind of symptoms you've had, how long you've had them for. I look for the big concerning things with regards to whatever the complaint is. And then I ask like, what have you been using for it? And then, that's how I start my note, my history of my history of present illness, my HPI. And then I do my exam, which I'll put in the computer at some point, usually kind of after the encounter, I'll fill that out. And then after I've done my exam and I kind of put that with the history together, I'm like, okay, here's what I think's going on with you. Here's what I think will help your symptoms. And then I order whatever medications, or if I feel like I need a chest X-ray or something like that, I'll order that. And then after the encounter is over with is when I try to finish the note. Depending on how long the encounter lasts, sometimes I can finish it before the next one. Sometimes I can't. Certainly depends on the day.
Yeah.
And depends on the patient. But usually by the end of the day, I've probably got about half or so of my notes done. Sometimes more than that if it goes really well. And so then when I'm done when my last patient is out the door, whatever time, usually my last appointment is like 4. So my last patient is out the door at 4:15, 4:30. Then I'm, doing notes until I'm done with those for the day. With my job, you have 2 days to kind of get your notes finished, mainly for billing purposes. I try to just get them done the same day. I don't like to leave a lot of notes. Yeah, totally. Because if you're not careful with that, they'll pile up on you, especially when the volume gets high. So, I mean, it's just easier to get it done.
How long does it take you to get like notes done? Like 10, 15 minutes?
Well, again, it's based on the volume, but typically between the notes and the labs, I'll probably take an hour and a half every day at the end of my day that I'm doing that. So, if I'm done if everything goes well and I'm done with my last patient at 4:15, I'm probably going to be there till 5:30 or 5:45.
Okay.
Not just clean up notes, but then there'll be labs from other encounters like the day before.
What does that mean, labs?
So like if I see a patient for like a physical and we're doing your basic screening labs that you do every year, like we check your electrolytes, your kidney function, your cholesterol, your blood count.
And you're reviewing those in labs?
Those get ordered and then the patient goes and gets the blood drawn and then those come back to me usually within a couple days.
Okay.
And so then I have to go through those results and like, is there anything wrong with these or are they all normal? Is your cholesterol a little high? And if it is, I send you a message saying like, your cholesterol's a little high. Here's what I do for that. Or if it's really high and you're a certain age, like, do we need to consider putting you on a medication to kind of manage that? So that's the other part of that's part of the reason that I don't have a 40-hour work week per se, but that's encompassed in what I do. So that's really, you really wind up working a little bit more than it seems like on the surface. Like I definitely probably work, 50 or 60 hours a week with all that stuff together.
Yeah.
So, but I mean, that's part of it,
And is it kind of like with any field, like when you first start off, like you don't have a lot of experience, you can expect your salary to be like on the lower end, you get, 10 years behind you, then now you're really starting to make some money and so on and so forth.
Yeah. The longer you've been practicing, the more you can kind of typically ask for up front. And that also gives you a lot more wiggle room with regards to applying to jobs, because most jobs want experience. And so when you first start out as a PA, when you first get out of school, you kind of have to take what you can get, unless you, well, the bulk of us worked during our clinical rotations. A lot of that is selling yourself, right?
Okay.
So you're kind of trying to show this provider that's watching over you of your competence.
Yeah.
Because if you have good competence, then they have an opening in their practice, or they can kind of steer you where they want to.
Yeah.
With regards to working for somebody. So it's kind of like you're not just learning, but you're also applying for a job at the same time. You're trying to make yourself hireable, if you will, or marketable.
So pay attention to that when you're in your clinical rotations. Yeah.
Yeah. It's all about making an impression.
Interesting. Yeah.
So you're not just there to learn. You want to come in looking like you know what you're doing. You know? Fake it till you make it kind of thing. Even if you have no idea. Like, strong and wrong is the fun saying, right? You just want to be as confident as you can. When you give an answer, clinicians like it a lot better a lot of times when you tell an answer and you just like confidently say that answer. And you might be wrong a lot of the time, but it looks better. I guess it just has this kind of look to it that
it makes me think of my first jury trial I ever did. I was by myself in an office, you know what I mean? And nobody was there. And I was like, oh, but I did the absolute best I could to try to give off as much confidence, like I knew exactly what I was doing.
Yep.
And but yeah,
that's what your patient wants, right? Nobody wants to go into a room with a provider and you just seem really like terrified of what's going on, or you seem a little confused. Like that just doesn't bode well. So that's what they're really pushing. Is like, you need to be comfortable in your own skin with a patient, and they will feel more comfortable, and then you both can kind of work together to figure out what's going on.
All right. So Kyle, you sent me some pictures. Want to take a look at those pictures now?
Sure.
Let's take a look at what you got. All right. So on the screen, we have your wife and a dog. Let's hear a little bit about them.
So my wife's name is Noelle. We have been together. We were dating for about a year before I went to school, and we wound up moving together to Virginia. We lived together while I was in school, and then we got engaged while I was in school and got married actually right before I graduated.
Cool. Where's that photo taken?
That photo was actually here at Saguaro Corners, one of our favorite restaurants that we go to, and that was right after we got our dog Scout. She was just a little puppy. I think she's maybe 2 or 3 months old in that picture. So, and then she has since grown significantly, although she's still pretty tiny. She's only about 23 pounds, but
yeah.
When I'm not working, those are the folks I'm hanging out with typically.
What kind of food is at that place? Saguaro? Did you say Saguaro Corners?
Yeah, it's like an American style grill, so a little bit of everything.
But it's really good. It's your favorite place?
It's one of our favorite spots. Yeah.
Why?
I think it's just close. They always have a bunch of different types of beer, and then we can usually share like appetizers, and that's a meal. So the serving size is pretty solid.
What's the good appetizer there?
We do the wings, and there's like a nacho or a tater tot thing that we really like.
Oh, wow.
Depending on the week, we do both of those.
This doesn't sound macro friendly.
Yeah, no, definitely not.
Yeah.
But those are who I'm working for when I'm working. So.
All right, so this must be from your military time. This is Air Force or Army?
This was the Air Force. This is when I was in Africa, actually.
Which one are you?
I'm the one there if you're looking at the picture, I'm on the right side, so with the bucket hat.
And the shades?
Oh, yeah.
Oh, yeah, there you go.
Yeah, I look a little different, I think, without a beard. But
where is this?
This is in Niamey, Niger, which is in West Africa.
Africa? How long were you there for?
We were there for 7 months.
Wow.
Yeah.
What was it like being there?
It's in climate-wise, it's not that different from Tucson. It's hotter, and it's sub-Saharan, so it's south of the Sahara Desert.
Is it humid?
In the summertime, yes. So when the monsoon season hits, It does get pretty humid there. But typically, it's really dry. It's just really dry and hot. Like I was there from around September to April, and so that's their. I guess that's their like wintertime frame, if you will. So it was a little cooler, but I mean, still days on average are, 110 or so. I mean, it's still pretty hot.
Now, is this at a base that's been established in Africa, or are you showing up to like a site that's already been, you know what I mean? Like,
Yeah, it was an air base. It was Air Base 101.
Okay.
Which is interestingly enough, I guess in the last 2 years, since I got back, that base is no longer there.
Oh, wow.
The government has changed and stuff like that, and so with everything that happened in that, because that's a pretty volatile region of Africa.
oh yeah.
We were about 2 hours from what's called the Tri-Border region, which is between Mali and Burkina Faso, which is probably one of the bigger hotspots in West Africa for terrorist activity. So that's kind of why we were there, as an intel, surveillance, and reconnaissance base. But I was in charge of running the medical operations there.
I know there's a lot of that tribal stuff going on, like people getting literally chopped up, and is that kind of stuff what you would see there? Or?
Well, when I was there, we would actually take care of, I took care of active duty and then contractors, but we also had a couple mass casualty events so our special operations guys are working with the Nigerian military, at least they were, training them on how to fight the terrorist organizations that are there. And so when we would take care of combat wounded patients, it would be Nigerian military personnel who would be coming in. So there'll be a later picture of some of the folks that I took care of during those events.
Yeah.
But then my day-to-day work was, in the clinic on base. So just taking care of.
Okay.
Your garden variety stuff, and then
So none of the civilian population in Africa.
There's contractors, federal contractors that are technically civilians. So I did take care of some of those. I actually had one with, basically he had like a TIA, which is a transient ischemic attack, like a mini stroke. So I spent my New Year's between 2021 and 2022 in the clinic, just praying for a medevac.
Wow.
But yeah. And that was Christmas. That's a couple years ago. That was how I spent my Christmas in the Army. So actually, it was a little bit cooler then. I would say it was like low hundreds.
Yeah.
But yeah.
Who made that sign?
I don't know. I think that was painted as part of like when they first built the base, and it became like a kind of local. Everybody goes to the sign when you first get there, and you got to get your picture taken. So we did it as part of our holiday celebration. I was able to send it to people as like a season's greetings kind of thing.
Yeah, I would have no idea that was you.
Yeah. I look just like Santa Claus, I think. So. And then this is kind of some of the stuff that I did. So the picture on the left is one of the opportunities I had was because it was a special operations base, they would go and kind of work with the locals. And so we ran a clinic. It was about 2 hours from the base I was at in the Tillaberi region of Niger, where they would just bring in a ton of people from the surrounding villages to where we had kind of set up an aid station.
Wow.
And we got to kind of treat the local population, which is what I really got into doing, this kind of austere type medicine.
Yeah.
And it was awesome. And then this is one of our mass casualty events. You can see there's patients on a gurney, and there was a patient I was working with that had several injuries, and we were actually, that's an actual X-ray machine. It's an very old X-ray machine, but an X-ray machine that we were looking, because he had a pretty significant hand injury. We were trying to figure out, does he have, fractures? We had already kind of assessed that he had some tendon damage, but which you can do with physical exam, but we were kind of looking to see what's the damage on the hand with regards to the bone structures. So, and this, the picture on the left is kind of the crew of people I probably spent the bulk of my time with while I was in PA school.
Yeah.
And then my friend that I've mentioned a couple of titimes before is in the right. His name's Brent. He's an ortho PA. He actually lives in Detroit. Works at Henry Ford Hospital up there.
So you graduated 2018?
2018.
No, that wasn't that long ago. I mean, it's getting to the point where it's getting longer, but
it doesn't feel that long ago. It's kind of crazy how many years have elapsed between now and then.
Are you ever going to go without a beard again?
If I want to stay married, the answer to that question is no. So.
That's funny.
Every once in a while to shake things up, to really, I joke that's if we have an argument, that's kind of my trump card. I'll just shave my beard.
That's pretty funny.
Don't make me do it, right?
Mm-hmm. Cool, man. Well, thanks for sharing those pictures.
Thank you.
Looking back, how do you feel about your decision to become a physician's assistant?
I think it's a great decision. I like I said, for me, I wasn't sure what area of medicine I wanted to work in. And the beautiful thing about being a PA is the flexibility. So most folks, if you have a specific specialty, you want to work in pediatrics, like maybe you should consider going to medical school and trying to do the residency route. But if you're not sure and you want to practice medicine, I think PA is a pretty great gig because you're never confined to a specific area of medicine. You can always, as long as you find a job where the provider you're working with is willing to train you or wants to have you, then you can work anywhere. And I've already switched specialties, twice now. And so I may ultimately do it again. I don't know what I will stay in, but I think, I think right now I like what I'm doing because it's pretty broad. I get a wide variety of stuff every day. So every day is a little different. It's never boring. And my skill set, because a lot of our training is generalist training. So that as soon as you get out of school, if you don't use it, you lose it. So it's a lot easier to maintain that stuff if you see a wide variety of things every day versus a specialty. So
what are the requirements to keep the license? Is it like a month or yearly, or what do you have to do? Is like continuing education?
For the state license, for Arizona, for example, you need like 40 hours of CME every like 2 years. And then some of that actually, I think 3 hours of that has to actually be opioid training in this state. Every state's a little different, but that's this one. And then nationally, every 2 years, you have to do at least 100 hours of CME.
What's CME?
Continuing medical education.
Okay.
And so they break that up. At least 50 hours have to be in category 1, which is like going to a conference or taking a hands-on course. So like basic life support, BLS, to have your first aid training is a recertification you have to do every 2 years or so. That counts towards CME.
Okay.
But then you can also do conferences or online courses if you want. So it really, the ability to get CME is kind of wide. It's just a matter of what do you want to do it in. If you do a specialty gig, like if you work in dermatology, you're probably going to do something in dermatology, right? If you do a generalist job like I do, then you do a little bit of everything. So I typically do online stuff that covers all topics, and I try to do just as many of them as I can in my 2 years.
Any regrets looking back, like, oh, I should have been smarter about this, or I wish I would have known about that?
I worked very hard in school. There was definitely modules where I was like, I don't think I'm ever going to use this, and like I am still kicking myself to this day because it was like, there's definitely times where I was like, I don't think I'll ever use that. And then I've had to go back and be like, wait, what was that again? Because I probably was like, oh, this would be one of those things that won't really come up as much as I thought it was. So honestly, the biggest advice I could give anybody that's interested in going to PA school is everything is relevant. Do not think for 1 second that anything is not relevant. And that's not like, don't freak out about it. But the goal is to learn as much as you can because you don't really know what you're going to use, and it's a lot easier to use it or to learn it and not need it than to later on be like, oh crap, I was supposed to have learned that and now I don't remember and I'm gonna have to figure out how to do that. So that's my two. I think part of that too is I was fairly certain I wanted to work in the ER, or like maybe I'm going to work in the ER. And then when I got out, I was like, I actually did my ER rotation and I didn't like it as much as my other ones. I actually like kind of getting to know my patients and following what's going on with them. And I feel like you can kind of learn more that way. And then the ER was just kind of like, you're here, you're not dying, have a good day. And so I know it's more complicated than that, but that was just kind of my experience as a student. And so for me, it was like, maybe I want to do something a little more kind of day to day with my patients or more involved in their lives. So
someone in PA school or going to PA school, would you say that it would be a good idea to explore those rotations, those clinical rotations, like try to get the things that you think you're interested in to kind of get a feel for that?
I was lucky too. I guess I forgot to mention that, we have core curriculum for the rotations, but there was an elective, at least in our program. So I actually did an elective in interventional radiology, which is really cool.
Interesting.
But I think you need to, on your clinicals, you need to find an area that you really like. And if primary care is it because of the wide variety of stuff you get to see, then that's great. If you feel like women's health is what you're interested in or that's your jam, then make sure that you really focus on that, because a lot of people come out And if you don't work in primary care, then you want to be really good at a specific specialty. And knowing everything you can about that is a great way to sell yourself, not only on the rotation, but on the job market. And that's how a lot of my friends found their jobs, is they knew they liked orthopedics. And so when they went to their ortho rotation, they did a really good job at their ortho rotation, and it was like they wanted to hire them for their ortho rotation. Nice. When they went to the ER, it was the same thing, right? It's like they knew they wanted to work in emergency medicine, and they were like, "You sure you don't want to work here when you graduate? Or if you do, here's my information. You should definitely look us up. Give us a call." So, like I said, a lot of it is not just learning, but you're selling yourself to whoever you're working with, or to the organization that you're working with, that, I can do this, or I will be able to do this once I graduate, and you should hire me. So, yeah.
Awesome, man. Well, I appreciate you being here, and thanks for sharing everything with us.
Yeah. Thanks for having me. It's been a great experience. Thank you.
For sure. And for anybody that's watching, if you have any questions for Kyle that I didn't get into, you can leave them in the comment section. I'll ask Kyle, and then I will reply in a comment. And thanks for watching, and we'll see you in the next episode. Bye. Cool, man.